My name is Dr. Monique Smith. I am an emergency physician at Grady, which is one of our safety net hospitals here in Atlanta, but in the larger space, I'm part of the Department of Emergency Medicine at Emory, and also the founding executive director of Health Design, which is our acute care design and innovation center. And I'll tell you that being the executive director of Health Design has been an incredible journey that we started on in December of 2019 with our new chair of emergency medicine, Dr. David Wright. Really kind of in this shared vision of moving from this space where we were just seeing patients in the emergency department who came to us really, having had, chronic diseases that were out of control, in distress, both in terms of socially and physically and emotionally, and really not always being equipped to give them the right set of tools to provide something in that moment, except for maybe an ear to listen with, right? So really wanting to kind of turn our view and our spectrum, not just being there when things are falling apart, but also being able to really think through this idea of how do we be there for people from a well-being perspective as well. Again, I'll give you the frame that this was December of 2018, where we really understood this mandate of ours to really kind of think through how we make acute care effortless and bring equity to well-being. And we thought about doing that across our ecosystem. We are fortunate to sit at Emory, which is a large healthcare system that spans a number of different emergency departments. Emergency departments that serve a tertiary academic hospital system as equally as it does a safety net, as equally as it does the community. And really understanding the diverse needs that live across that population and realizing the way in which we weave together care has to account for that. And wanting to really think through innovation within this space, keeping all of those elements, all of those individuals in mind. And then in the larger frame of what Atlanta is, being right next door to the CDC, across the highway from Georgia Tech, Morehouse, Spelman, SCAD, at the nexus of what is happening in this digital health space, this revolution that we really kind of focused in on in the last year, and understanding how we have a critical role, not only for our patients, but for our communities and also for health equity to help build that and bring that together. And then the global scape, understanding very much that one of our core values has always been this idea of what we're building here is something that we should be able to use no matter where we are in the world. Now, the way that we deliver it, the channel, the implementation, the adoption, that has to get really specific. But we're all facing the same types of problems. And that's something that COVID has made abundantly clear to all of us. So really kind of continuing to understand how the critical role that we have to play with that. And in the name of COVID and everything else that was 2020, we brought that mandate of, kind of understanding how we affect change in this space of making acute care effortless and bringing equity to well-being, but really zoned in with our COVID lens, kind of think through what role can we be playing. And we certainly did that with our partners at In On Health in launching a messaging campaign and a model that used nationally, but in the metro area, reaching 125,000 individuals, sending over 1.5 million messages, and really partnering with everything from the small minority-owned businesses to some of our key frontline workers out there, as well as healthcare systems and community healthcare systems, as well as grassroots community organizing groups and activists as well, to make sure that people were getting critical information in the right channel at the right time in the midst of a lot of uncertainty. Making sure that we're leveraging that in an intelligent way. And then also within that, partnering with our partners at Vital and kind of thinking through early in the pandemic in early March, rolling out a symptom checker, now have over 1 million uses globally, and thinking through how that's something that was web-based and that could reach people and help them to navigate the uncertainty of what it meant to have what we didn't know, were this flu-like symptoms that were COVID, but then also flipping that to a global perspective with Access Mobile to think through how we make this accessible to people who only have basic phones and aren't connected with the same sort of connectivity, so they'd be able to get it through text message as well as a USSD flow. And then within our own ecosystem, even in the midst of the pandemic, really thinking about how people don't fall through the cracks and using elements of our patient experience that Vital enables for people to understand their flow through the emergency department, but then also to be able to be brought into care that's necessary, that doesn't happen in an urgent situation. But if you let it go, it becomes a big problem, right? And so being able to really, even just within that context of the pandemic where we were having a lot just slip through the cracks, being able to increase follow-up by more than 5%. In the arc of who we are and what we're doing, we certainly care a lot about thinking about what happens to people before they get to our emergency department doors, when they're sitting at home trying to understand these first bits of symptoms of illness and how they think about navigating the healthcare system. And of course, kind of within that bucket of once they're here, making sure that experience is streamlined, it's connected, that people feel heard and engaged or getting the care that they need. But then also thinking beyond those walls, beyond those doors, how we make sure that people are, being cared for in the right place and in place as well, with new tools and with new experiences that meet people where they're at. Within that, we kind of must think about reflecting our world. We must be very intentional about bringing in partners that really embed equity at the center of that, because we all know that as we innovate, we can start to replicate the same social hierarchies that we've created in the past. So we've really thought a lot about how we put health equity at the center of that. For me as a physician, coming through training, I can think of the number of times, probably on one hand, where I saw clinicians that looked like me, and also training in Boston in a tertiary hospital where I saw patients that looked like me, because I didn't train in the safety net hospital when I did my medical school, unlike in residency. And part of that then reflected in what is the core of medicine and how we practice and deliver care. And a lot of that, from the medicines that we prescribe to the way we think of our algorithms and the patterns of disease, it's been formulated around the idea of not just a white male, but a white male of a certain weight and of a certain kind of space in the social system, of a certain level of access, has a certain ability to navigate. And we can't make that same assumption when we're thinking about how we deploy our digital health tools to really, get to these elements of increasing access, get to these elements of addressing health equity, and fundamentally being there for people. When we think about the different levers that we have to deploy, whether or not we're thinking about, AI and machine learning from a decision tech perspective, or whether or not we're thinking about using different channels, be they voice, be they, app, anything that we're deploying to really contact people and engage them, or it's connected tech or mobility tech, we've got to be really thoughtful about the way we do that and deploy that in an equitable way. So I'll phrase again, where have you seen inequity in digital health? Where is that coming up for you, whether it's personally or in your day-to-day work or experiences in your ecosystem and in your community? We certainly have had some big conversations about the sort of bias that exists in AI and how AI is certainly powering, the way we search on Google, the way that we, receive our email, the little pop-ups and alerts that kind of know who we are suddenly. Even within that, in our own experience in this past year of creating an automated triage tool, a tool that would allow us to screen for vital signs and for people who were short of breath without coming within that social distance period when we were having those early waves of COVID. We realized that when we did the training data set on a data set that only had light-skinned faces, what we were going to pop out with on the other end was not going to be equitable. So having to be very thoughtful then, even when we're creating these algorithms, when we're relying on AI and machine learning, that we're thinking through what those training data sets are training on and making sure that we have representation there. When we think about the more recent reports and studies that have shown that pulse oximetry can have a pretty big differential in terms of accuracy when measured against the gold standard, whether if your skin is fair versus being darker, seeing that 2%, in that discrepancy for folks who are fair skin, measure that against a blood level of your oxygen levels versus with people with darker skin, there's a 12% difference. You think of the impact, the significance of that for a pulse oximetry, something that tells me your oxygen level in the middle of a pandemic where we're sending people home and telling them you'll be okay based on numbers like that, right? And you start to understand the complexity of how technology can enable inequity rather than supporting access and getting to people better at the last mile. And then we think about the digital divide. We think about how we live across rural and urban environments, what lives in our environment, and also our connectedness amidst that, and how there's 96% of us in this country, in the US, who own a cell phone, but that's only 81% with a smartphone. And when you look across that from a race ethnicity perspective, you see a quarter of Hispanic individuals in this country are smartphone dependent, with a little bit less than that 23% of Black individuals being smartphone dependent. And what that means is that when they go home, there's no broadband. So the only way to get information, to navigate to that vaccine site, to understand what's going on with COVID, to get a new appointment, to have that virtual visit is on this phone right here, right? So you've got to take that into account when you're thinking through designing for all populations, right? And even within that, of course, I don't know if the rest of you out there have had as much frustration with your Alexa as I have, but every time I say something, she doesn't understand me. And my husband speaks in 5 rooms away and she knows immediately what the weather is, right? We know that there are pieces of technology that are still evolving when we talk about voice, right? We know that accents can affect things. We know that pitch can affect things. And we think about how that replicates the structures that we already see in the patient experience, where we already have, entire patient populations that are frustrated that they simply don't feel heard. So it's something that we have to be fine-tuned around and how we deploy it and make sure we're really giving patients a space to be heard and attended to, because we know that matters so much within the patient experience. We also have to be thoughtful about this idea of cultural concordance, right? Knowing that it's really hard to create trust virtually. So how do we leverage the tools that we have at hand to do that, right? And understanding that that is one tool amongst a slew of others that we can use to create that space. So a lot of that talks about how do, the elements of technology that have room for failure. But today we're really focusing on, how do we innovate in a way that catalyzes equity? Coming back to these common sense design principles, really, where we're accounting for the reality of the structures that exist in our society, whether we're not talking about race, ethnicity, gender, or we're talking about being able-bodied, or we're talking about, rather being LGBTQ, whether we're talking about, where you live in the zip code and all the other elements that come along with those pieces as well, and talking about marginalized communities as a whole. And understanding that when we account for reality inherent within that, we have to be explicit about the implicit biases and perspectives that we're bringing to our design elements, right? It's a key part of what will really ground us today as we go through a set of themes and prompts to kind of help us through this journey of thinking how we reach those next steps of equitable tech-enabled care.